Okay, so next up is, I'm just going to say Dr. Z. He's going to introduce his name for you. But he's board certified in addiction medicine, and Dr. Z has just a lot of knowledge and just a passion for what he does in helping his patients. So please welcome Dr. Z to the stage.
Hello. I did the same presentation a couple of weeks ago, and the way we did it, I took questions, and it was more interactive, so it worked. Can you hear me? So it worked well because I actually addressed what subject people have been asking about and things you guys need to know more about instead of just give a speech. I think I have few questions which I'm just gonna answer, but meanwhile just stop me and ask me any question which come into your mind. So I think the first question is, who has acute pain and what is chronic pain? By definition, really, it's just how long they have been having the pain. So by definition, if someone has been having pain more than 12 weeks, then we would say that's more of chronic pain. But it's important for us to differentiate between acute pain and chronic pain because it's completely different. Go ahead, please. Sure. Does work better? Sorry. So it's different how actually how your body is responding to the pain, and that's why it's so different in how you treat pain. So acute pain, we can all think about it that it's an injury. It's our body alarm that there's something wrong going on with us and it needs to be addressed and needs to be treated. It's when the tissue is very inflamed, it's very angry, you have a lot of blood flow to the area, you have a lot of immune response to the area, like we were talking about, like an acute disc herniated, someone who has broken bone, someone who has appendicitis, or he has a gallbladder problem, something which acute, it's showing us that there's an acute problem needs to be addressed. Unfortunately, opioid is very inappropriate treatment in those situations unless the pain is intolerable and is very, very bad, because every study showed if you start treating acute pain with opioid early on, the chances of this pain become chronic is very high. So we try to avoid any opioid treatment for acute pain unless it's very much needed. Chronic pain is different. Chronic pain, I have been having this nagging pain, all of us, I think, I mean, I had it, I think a lot of you here had it, when you had pain in one part of your area which is just nagging, it's just there. You wake up with it, you go sleep with it. Sometimes it's aggravated, sometimes it's preventing you from functionality, sometimes you're not able to sit for a long period of time, you're not able to run if you're a runner because it's hurting you, it's just taking something from your life, but even when you're not active, it's just there, it's just nagging you all the time. Then the nature of the pain is different. So right now you don't have just the injury, you have how your brain is responding to the injury. And that's when you have more centers in your brain which is involved in the pain. That's when you're gonna start having problem in your sleep, when you're gonna start having problem in your mood, when you're gonna become the pain, how you actually understand the pain, how your brain is responding to the pain, and that's when opioid is prescribed a lot of times, and actually what it does, it would not improve some functionality. We're gonna talk about the problem with opioid prescribed at this time, but what it does, it masks it for you. But the problem is still there. The problem is how your brain is responding to it. When we actually evaluate pain to see if pain is controlled or no, all studies right now does not evaluate pain with our ridiculous pain scale that just tell us from 1 to 10 where your pain falls down, and most people respond that it's 9, 8, or 7. What we really need to evaluate pain, especially when we're talking about pain, we evaluate with functionality. How are you functional with the pain? What things which you want to do in a reason which you're not able to do? And that's what we want to improve. Are you sleeping or no? Are you able to sit or no? Are you able to go to the movie theater or no? Are you able to cook or no? are you able to do your job or no? That's the thing which actually evaluate pain, and we want to improve a pain to it. We want to improve functionality. And then when we put it in a question like this, patient is able to understand it, and he able to report it in a measurable way more. So when we start helping him and treating him, we can actually measure if that is improving or not improving, versus just to get into a subjective number where if you are having this nagging pain all the time, you're always going to report this number to be high, because really it's always going to be there and it's not going to go away, and it's going to make you very depressed unless we start improving your life in general. So I think what chronic pain is, it's not just the pain, it's how it's affecting your life. And what we want to treat is not just the pain. We want to treat how you function and how you improve your life quality. And then I think you naturally is going to start reporting your pain number to be lower. Treating acute and chronic pain. Chronic pain, you have so many things go into treatment. So you have multiple medication which can be used for treatment. Things which mainly affect pain centrally, how the pain respond to the pain stimuli. So opioid would be one of those treatments. Sometimes it can be treated for people who have chronic pain and has been suffering of it and is very severe. I think what I always emphasize in my speech is right now, in this time we're living in, we started seeing a opposite problem. So we still have the overprescribing. We still have a lot of providers who overprescribe opioid, but we started seeing something which becoming more and more common is the lashback of the community and providers of being so afraid of opioid and having people who have been on opioid for a long time getting cut down and not prescribe opioid anymore. And I think that's presenting as much danger as it was before, because what is happening, we already had people who have been on chronic dosage of opioid for a very long period of time. They are already dependent on opioid, and we simply cannot just cut them off, because when we cut them off, it's no one really, like I have doctor once told me that no one will die from opioid withdrawals. And I agree with him, no one will die from opioid withdrawals, but opioid withdrawals is so severe, so very few people can actually go through opioid withdrawals. So when we're pushing someone to go into opioid withdrawals, what we're really asking him to do to go buy something off the street. And when they're buying something from the street, they're dying from overdose. So no one really die from opioid withdrawal. I 100% agree with this, but there's a lot of people who will die from opioid overdose. I don't know if you guys have any questions so far. Go ahead, please.
If you're dealing with an angry patient, and he's angry because opioids are being tapered, and he comes in and he says, no therapy will work for me, nothing will work, you don't care about me, you can't do anything for me. What am I supposed to do about all this pain that you're helping cause to have happen because you're taking me off of opioids? And what do you find is the best, or some of the best guidelines to try to be supportive of a patient like that?
So I think angry patient, I think you will have different kinds of angry patients, right? So I think you will have people who might be angry because they want script, because they sell the script on the street. I think in this situation, he's trying to intimidate you. So I think we should not buy into his intimidation. And I mean, we can figure this. I mean, you can figure this with drug screens. You can figure this with his kind of behavior. On the other hand, you have angry patients who I think they have a concern, and I think the concern has not been met, and I think they not understood correctly, and they're trying to be an advocate for themselves, but because they're very frustrated, so they are presenting themselves in this hostile way. And I think part of this hostile they're presenting themselves in is just because no one really understanding what they're saying. So I think I'm gonna put two different kind of people who takes opioid who go to primary care. So you have people who have true addiction, and then you have people who have a dependency on opioid. True addiction, of course, people who misuse their medication to get high on. People who, the higher population, actually patient who has been on opioid for years and they're just dependent on opioid. And what they are afraid of then getting tapered off opioid because they have horrible withdrawal symptoms. And I will tell you from experience, those are the higher population. So people who have addiction, when we're addressing this for them, and I see this over and over, that it always gets addressed that you have problem with opioid, you have been abusing your opioid, we're gonna cut you off and then we're gonna send you for therapy. Or we're gonna cut you off and you need to call and get yourself into an inpatient rehab so they can get you off opioid. One, I mean, I asked about the audience. I know there's a lot of social workers and a lot of counselors here. So I mean, we all can agree that you cannot go someone with motivational interviewing and tell him that I think you have an addiction. That you just put a block on the conversation and he's just gonna be defending himself from this point on. So I think you need to make him understand where your concern coming from and make him come to the understanding why you are concerned and give him a very legit solution. You cannot tell him go to inpatient rehab. They're not gonna take him, one, and even if they cannot take him, he needs to know where to go and what kind of option he has. And a lot of us in primary care ward, we don't even know what inpatient rehab look like and how difficult sometimes it is to get into. The other thing, therapy is not gonna treat someone who has an opioid addiction. So I worked for almost 5 years into a outpatient clinic, and we had kind of protocol that whenever we're cutting off someone from opioid, because of a concern for abuse, we give them a referral to our counselor so they can start getting into therapy. You cannot do that because someone who's actively having opioid withdrawals and have opioid addiction is not gonna even make it to his appointment in therapy. He's not even in stable mindset to be able to be in therapy. So I think understanding that would help to decrease this anger, that we actually have to hear from them and make them come to the understanding that I have problem. What is the solution could be for a problem like that? The other one is people who have dependency. And people who have dependency, what they get faced with a lot of times, they get faced with a decision that their doctor decided that I'm gonna take you off opioid, and that's how we're gonna taper you down. To be tapered down opioid, it's a very difficult and very long process, and your patient should be on the same page with you. If he's not, you're gonna fail. It's not gonna work. And you have to understand also why you're doing it. And he has to understand as well why you're doing it, and he has to be agreeable to it. Just an example, I got a text message actually from a colleague this morning that she was asking me about patient she wants to taper down. And this patient is an elderly lady who is on methadone, and she has been on methadone for years, and she has been on Percocet, and they stopped her Percocet, and they have been tapering her of her methadone from 80 to 50, and they're not able to taper her down more than that. And last time they had an appointment together, she was very tearful, and she was crying, and she was thinking that she's gonna kill herself, and her husband was saying she's miserable. And I asked her, why you want to taper her down? And she was, because we're just concerned of the dosage she's taking of methadone. She never had any abnormal drug screen. She never showed any signs of abuse. Part of it is not her fault that she has been on those opioids for this long. But now we are kind of penalizing her because we want her to be off opioid as soon as possible. And I think that, I'm not sure if that's answered your question, but I think it helped to be able to work with the patient as a team, because that will decrease a lot of their anger. And a lot of times that's not what happens. A lot of times in our offices, we actually giving a recipe for a patient to be extremely angry. Opioids come in two different kinds. You have short-acting opioids and long-acting opioids. generic street names for short-acting opioids, most common people know about would be Norco, Percocets. They're really not appropriate for anything. They're not appropriate for any treatment. They are prescribed for acute pain. They never should be prescribed for chronic pain. Sometimes you see some clinics, they will say, well, we're gonna put someone on long-acting opioid, and then we'll give them a short-acting opioid for breakthrough pain. It really does not work this way. So what short-acting opioids is gonna cause people to go into a cycle of feeling good, feeling bad, feeling good, feeling bad, feeling good, feeling bad. This is exactly how your brain functions with addiction. Think about it like alcohol. Think about it like cigarettes. When someone lit a cigarette, he will feel good for a couple of minutes, feel bad, will try to maintain himself, but he's just so much craving this next cigarette to be lit. That's how short-acting opioids work. And let's put this in someone who has chronic pain, who we already said that he is depressed, he's not feeling good, he's losing his job, his life's changing, his family function, his family dynamics, it's changing, and then you're giving him medication, which he can feel high on it, he can get good on it. You're giving him something which he easily can get hooked on and get addicted on, and then that's just a recipe for someone to get hooked on medication. And that's why we try to avoid short-acting opioid as much as possible. Long-acting opioid has lower risk of abuse. Someone met me outside and they were asking me about other medication which prescribe of abuse or whatnot. Anything can be abused. Anything can be misused. People can get addicted on any single drug. People get addicted on Prozac. They can misuse and abuse Prozac. But it's less likely. So when we talk about something which would be less likely, it's just the fact that it's less likely to be abused. So long-acting opioid is less likely to be abused because even when it gives a high, it's not going to be a high like short-acting opioid. I'm not sure if anyone have any questions for me. So taper.
I don't need a microphone. I can talk loud.
Sure.
So I'm just, because I'm not in the medical field, I don't prescribe meds, but I work with a lot of clients in chronic pain. Can you just you listed a few of the acute ones. Can you list a few of the long-term acting ones?
So the list is very long. So I'm going to just tell you which is more common. So those are the things which is more commonly to be covered with more of insurances. So you'll see it more used. So morphine comes into two forms. Morphine comes into short-acting and long-acting. So morphine, you can see it as a short-acting or you can see it as a long-acting. Things which would be more long-acting would be kind of like fentanyl patch, but even fentanyl patch can be abused if people chew it, because when you apply it on the skin, it would be more of long-acting, but when you chew it, it would be more of short-acting effect. And then you have methadone. Methadone would be a long-acting solution. So those are be the most common medication would be used. So morphine would be, morphine extended release is the most common long-acting opioid would be used. The list go on, the list is very long, but those are just the most common you will see. One of the short-acting, and it's really it's a synthetic opioid. It's called tramadol or Ultram, and it's misconception that this is not addictive. It's a very powerful addictive drug. It works not just on the opioid receptor; it's actually increased serotonin. So it gives a different kind of high, and it's very addictive, and it's very difficult to get off as well. So just to keep in mind. One of the things which people ask about would be taper off. How can you taper off opioid? And tapering off opioid is a very long process. It takes very long time for someone to be able to get off opioid. It does not happen in 1 week. It does not happen in 1 month. Sometimes it can take 2 to 3 years to be able to get off opioid. And I think a lot of times what we see over and over again, especially now with this quick flashback, that people want to get off opioids or primary care. try to get people off opioids in a very short period of time. And it really does not happen. It cannot happen this way. One, you cannot taper off people off short-acting medication. So I cannot taper off someone who's taking Norco or Percocet or Ultram because, again, think about it like you're tapering off someone who's smoking or drinking by asking him, smoke 1 cigarette less a day, or drink 1 shot less every day. It just would not work because you still have the process in the brain and he's waiting for this trigger and he's just gonna continue to wait for it. And a lot of times what is gonna happen is gonna be the opposite endpoint. You're gonna have the opposite result, that because they have been craving for so long and because they having this frustration building up and building up, they can relapse to start taking more instead of start taking less. And because their primary care doctor is getting their script to be lower, so what they can do, they can start buying from the street to substitute. Sometimes in our mind, we would think that if you are in a certain socioeconomical class, if you are in certain profession, you're not gonna go to the street to buy drugs, and this is far from the truth, because you will have different resources from the street to buy drugs, but drugs are very available in the street and it's very easy to be obtained. So, and it does not matter what you do for a living. I had people who are very highly professional. They have a very high professional work in very good companies, and they were buying heroin off the street. They have different resources to get heroin, but it's very available. Taper off, we
have a question.
Hi, I just was wondering, when you're treating people who have an opioid dependence, do you ever find a use for naltrexone?
No, and it really should not be, because people who have dependency, they're not craving their medication because of seeking the high of it. It's just a withdrawal symptoms. So I see this a lot, that we want to get someone to be in an inpatient rehab to get them off opioid and then putting them on naltrexone and send them home on it. They're not gonna crave opioid. Their problem is that they are just having those horrible withdrawal symptoms whenever they're trying to go down on their medication. Some of them can do good in a very short period of time. So sometimes you can do a very quick taper in an inpatient facility. I will never do a quick taper as an outpatient, but in an inpatient facility, you can do a quick taper and they will be okay. And usually they will report for you if they're having any craving or no, although you really, with true dependency, you're really not gonna have any cravings. On the other hand, naltrexone is not gonna help you unless you have this craving. So really it's gonna take away your craving. What you see problem with a lot of times is people who have chronic pain and they have opioid dependency and they have been titrated up to an extremely high dosage, which a lot of people are not comfortable continue to prescribe anymore. They do have legit pain. And those patients, usually the expectations is to get them completely off opioid, and that's not realistic expectations because they have a chronic pain. They have already been on opioid. It's very difficult to try to manage it completely without opioid, even with supportive therapy, even with supportive measures. It's so difficult to get them to really get functional without opioid. So at one point, those patients, we need to be realistic sometimes that they can need to be on opioid, but maybe a lower, more reasonable dosage, but it might not be 100% realistic to be completely off it. And I see this a lot. I see a lot of times people come to an inpatient rehab and to be tapered completely off opioid. And sometimes I see them outpatient, and sometimes we manage them just an inpatient. So when they are inpatient, a lot of times we put them on a lower dosage of Suboxone, and then we send them home on Suboxone. And sometimes if we made them completely free of Suboxone, and I follow up with them as an outpatient, what they end up doing, someone else is gonna put them on opioid again.
Vivitrol.
So Vivitrol is naltrexone. So Vivitrol, what Vivitrol is, it's an opioid blocker, and what it does, it helps craving. So Vivitrol is perfect medication for someone who has been chasing the high. And it does not work just for opioid. It works for opioid, it works for alcohol, as well as it works for food, believe it or not. So if you're not chasing a high, if my patient is not chasing a high after the opioid, Vivitrol has no role in treating him. So we're talking about people who just dependent on opioid. They do not have any misuse of opioid. They do not get opioid to get high on, but they have been on high dosage for years, and whenever they try to cut down on their dosage, they get withdrawal symptoms. Those are people who do not have an addiction. They're just dependent on opioid, and Vivitrol was not going to be helpful in their case. Does this answer your question? We were talking about tapering down again. So with tapering down, I'll taper down just with long-acting opioid. I would not taper down with short-acting opioid. And again, it needs a very extensive, long period of time to be able to taper them down. You have to hear back from them. Again, the example of the lady who was on methadone. I mean, we have to just understand that someone on methadone, to be able to get them down, if we're able to get them off completely, it's going to take few years. It's not going to take a short period of time. It's really have to hear back from them. You have to understand that when you're tapering off opioid, people is going to start having emotional imbalance. It's a very difficult time they can go through. You have to be prepared that they can have enough support while you're trying to taper them off opioid. What I can tell you, what is happening in the community right now, that what happened most of the times, the scenario would be that you take too much opioid, their doctor retired, not practicing, for one reason or another, they're not very comfortable prescribing this for them anymore, and then they will tell them, you're taking too much, we're gonna start tapering you down. You see this multiple times, that you're taking Norco 4-6 tablets a day. We're gonna cut down 1 tablet every week, or we're gonna cut down 1 tablet every couple of weeks. The expectations of the provider that I'm gonna need to get my patient off opioid within 2-3 months. The patient is not accepting this plan because they, 1, afraid of withdrawal symptoms, 2, they still have their legit pain and they are afraid what they can do with their pain when they're off opioid. And what they can do, they can start trying to find another doctor. The other doctor is gonna see them, they are doctor shopping, and it's just gonna do this whole cycle of misery for the doctors and the patient. I hear a lot of times about, I'm gonna prescribe opioid for a very short period of time for acute pain. That I did not give too much medication. I just gave 3 days worth of medication, 4 days worth of medication. Someone broke his leg, I just gave him 20 pills of Norco and sent him home with it. We have to understand that addiction can start with 1 pill. So really it does not matter how much we prescribed. The decision of handing someone script of opioid, it can be changing their life, even if it was for 10 tablets. And you hear this over and over a lot of times, that I started, something clicked in my brain, I felt different, and I never got back the same after I took my first pill. I think that's what gets us to the understanding of addiction. And current life addiction, I mean, we're not just addicted to opioids, we're addicted on so many things in life. We are people who, we mastered how to mask our emotion and our trauma. We think that we should not be weak. We think that we should not present our weakness. We think we should mask it, and we think we should hold everything together. And what I'm doing, I'm giving you a pill, which definitely is gonna help you to do that. And I think addiction can start with 1 pill. And what I usually give examples, so I always get opioid to be mimicking something else. So think about it that I'm gonna give someone 10 cigarettes and tell him, you're just gonna smoke those 10 cigarettes right now because you have toothache. But then after your tooth is okay, you're gonna stop smoking. Or I'm going to give someone a line of cocaine because they have a headache, and I'm going to tell them, you're just going to get this line of cocaine and you're not going to take anything any further. Well, why those are so much no, and then it would be okay for me to hand a script without so much of be cautious about it of Adderall, or handing script for Xanax, or handing script for Norco, because people can get addicted on those drugs with one script, with one pill, does not need to be on 3 months or 4 months or 5 months before you get addicted. You need few months to be dependent, but you're not gonna need few months to be addicted. You can get addicted on it in a couple of days. So other thing which I think I would love to speak about with opioid is the fact that it's almost never just opioid. It's almost always opioid and benzos get prescribed together. So you see a lot of times, so we were talking about short acting, so you see a lot of times people who get prescribed Xanax with their opioid, they get prescribed Klonopin, Ativan, which are more long-acting. Xanax is the one which is more common. And I think that's the other addiction which community does not talk much about, that we are in an epidemic of addiction to benzodiazepines. And if we're gonna talk about taper, and the reason why I brought this is the taper, because people don't understand that tapering person off benzos are so much harder and it takes so much more work than tapering off opioids. So when we're talking about opioids, you have to be careful and you have to be patient. Benzos, it's an extremely hard work. People who has been taking high dosage of benzos for a long period of time and you try to taper them off, they will have an extremely emotional imbalance. They will have a very horrible anxiety. They become very non-functional because of their anxiety, and it really needs very long time and be very patient, change them to other medication to be able to control their symptoms. Tapering off benzos is not an easy job. Anyone has questions for me? Go ahead, please. All right, so things which we use to be able to get people off opioid are things which can mimic opioids a little bit, but they are a little bit more long-acting. Keep in mind that any medication which can affect opioid receptors can help for pain. So those medications can be used for pain, but also can be used to be able to taper someone off opioid and to be able to help someone who has an addiction. So I'll start with methadone because it's the longer has been in the market for a longer time, and we know about it much. So methadone is a very strong opioid. It's when it binds to the opioid receptor, it just binds in a very strong way. So someone who takes methadone, the methadone is not going to let any other opioid come and bind to those receptors because it protects those receptors. So we use this when methadone came in the beginning to treat addiction. It's the reason why, because if you take methadone and then if they had a relapse and if they want to use heroin or if they want to use hydrocodone or something like that, they would not be, it's not going to affect them as much. They can still get a high, but not the high what they are used to. So methadone, though, talking about it, that it's still can connect to the opioid receptor and it's opioid by itself, it still can affect you as a true opioid. Because it's very long-acting, it does not give the high which short-acting medication give it, but still can give a high. Methadone, some higher dosage you get, the more effects you will get from it as far as giving you numbing into your brain. So when we talk about methadone clinics, most of the time what we say that they will start you on a dosage and then they will taper you up, depends on how much symptoms of cravings for drugs you're having, and then gradually they need to taper you down to be on a dosage where it keep you functional, but at the same time it's controlling your cravings. So a lot of times you don't see that. Some methadone clinic do it, but a lot of methadone clinics do not do it. So what you end up seeing people on a really high dosage. So high dosage, I mean, I'm not sure if you deal with dosages or no, but you see people who takes 120, 130, 190 milligram of methadone. Those are not a maintenance dosage. Those are more of a high dosage, especially if you mix those with other things, which most likely they do. Because not with Methadone Clinic, but that would be their primary care doctor and their pain clinic. So they would be on gabapentin, on Norentin, they would be on Valium, on Xanax, stuff like that. So you make this with methadone, it would get high. Methadone by itself can overdose on it, so people can die because of methadone. And unfortunately, I mean, I witnessed a couple of times people who overdose on methadone and die because of it, because methadone, when Narcan is given, Narcan is very short acting, where methadone is very long acting. So if someone overdose on methadone and you wake him up with Narcan and decide to leave, he's gonna just collapse and maybe an hour later, because that's when Narcan is out of their system. So that's methadone. And then you have the other medications. So buprenorphine is a medication. That's the name of the medication. And it is in different forms. So you have Subutex or Suboxone. Those are all has buprenorphine in it. So buprenorphine, it's a little different. So what it does, it's a partial agonist for the opioid. So it does not connect to the opioid receptor completely. And that makes it different in two ways. One, it's less likely to get high on it. And just to answer the question which I got outside, there's nothing which you cannot abuse. So even when we're talking about buprenorphine or Suboxone, people can still abuse it, but it's less likely to abuse, and it will give you a less of a high. So it's less likely to be misused. So what it does is partial agonist. So it does not, when it attached to your brain, it does not attach completely, so you don't continue to get this extreme high. It saturates your brain in a certain level, so there's no point in keep titrating up the dosage. So if someone decided to take more and more and more of buprenorphine, he's not going to get more effect and more effect and more effects the higher he goes on dosage. He will just, at one point, that's all you're going to get. Even if you take more, it's not going to affect you anymore. Subutex and Suboxone, they're just different. Suboxone has naloxone in it, and that's to prevent it from getting shut up. You know, people cannot just do an IV on it. Subutex does not have naloxone in it, and we give it to ladies who's pregnant, because you don't want them to give naloxone when they're pregnant, because you want to avoid any withdrawals for them. But both of those medications have buprenorphine in it. Other things which we use as well, there is a implant of medication similar to buprenorphine. So it's implant, and it works for 6 months. So it's the same thing, but it would be under your skin. It's similar to the birth control implant, and it just sit there for 6 months and gradually give the medication. And then the other thing that actually just got FDA approved, and they start using it. The problem is still insurance, because it's new medication. It's shots, so it's buprenorphine shots, and those last for almost 4 to 6 weeks. Naltrexone, it's completely different. So naltrexone does not have any opioid effect. It's an opioid blocker, and it's long-acting opioid blocker, and it helps to fight cravings. And that's why we use it for alcohol. That's why we use it for food, because it stops the positive reinforcement. So when someone, I try my best not to tell my patient this fact, because patients are so scared of using what they're taking naltrexone, because they think they can get withdrawal symptoms. They don't get withdrawal symptoms. I try my best not to correct this misconception for them, but it's really what naltrexone does. They do not get the positive reinforcement with the drugs, so they still can get high. There's concept that I would not get high if I'm on naltrexone. They still can get high, but it's different kind of high. It's not as good, and they are less driven to use it again, because it does not give them this much of a good feeling. Any questions? Please. So I can tell you what I definitely recommend. I recommend 100% to not give anyone opioids, unless I'm dealing with something extremely bad, like something which untolerably people cannot take it. what I would recommend NSAIDs like ibuprofen, Tylenol, something local like Lauderdale, Biofreeze, ice, heat, stuff like that. Keep in mind that we use, depends where you read it, but like last time I read it, it's like we use 95% of the world opioid. So we cannot be, as a nation, so sensitive for pain more than anyone else in the entire world. So I think our idea that we want our pain to be zero, it's just not realistic. If I have broken bone, my pain does not need to be zero. It's okay for me to continue to have pain. I don't have to be 100% comfortable. It's okay to have pain. It's okay to have 4 or 5 pain. Unfortunately, that's not what people do. Unfortunately, we want the patient to be 100% comfortable with no any pain. And that's why a lot of those treatments reported as a fail. But then if you go into the functionality scale, not the number scale, you will see that actually with functionality, nothing has been different. So if someone has pain and he has broken bone, and you ended up giving him Norco to make his pain level go down to 2, and then you saw what he was doing before his number was 2 and what he did after his number was 2, it's exactly the same. And that's why we should just avoid this number and just have a lower expectations of how we want our patients to be comfortable. And sometimes pain is good for you because pain will give you an indicator what is going on in your body. You need to be in harmony with what's going on in your body. Yes, please. So I don't treat pain myself, but I get consults from pain clinics sometimes. One of the things which I think it's a little tricky because you have the hyperanaesthesia with opioid. So sometimes what happens with the pain threshold, that really is not that they having higher pain threshold, but what happened with opioid, because with chronic pain, remember, it's the brain more than it's peripheral. So sometimes what happens, the more opioid you give them, the more feeling of pain they will get. And that's what hyperanesthesia is. It's people who have been escalated higher and higher, and the more you're giving them, the more pain they will get. And this is very sensitive way to treat, because really the way to treat them is to bring them down as much as possible. And sometimes they can benefit from being on a different medication. So sometimes they can benefit from being on buprenorphine because it works in a different way. There's other kind of synthetic opioids which sometimes can work for them. Now, if we're not going to talk about hyperanaesthesia, if we're talking just about someone who have just high tolerance for pain or lower tolerance for pain, I think it will get me back to the functionality. So I would not say what just his reporting his pain number is, but I will focus more and more and more about what is your pain preventing you from doing. I will address it as much as it's affecting his functionality. So it's different than someone is telling me my pain is 8, but he has been, let's say, back pain. His pain is 8. My next question is, how long can you sit? You know, those are something I can measure. So if he told me, I don't have problem in sitting, are you able to sleep? I don't have problem in sleeping. What's your problem is? I'm not able to clean my yard. I don't have to escalate his pain medication because that's not a realistic task for him to do with his back injury. And I see this a lot, even in primary care, you see this a lot that someone who has chronic pain and they come with aggravated pain. What did you do yesterday? I had my spring home cleaning. What spring home cleaning? Well, I got up and I got the drapes down and was like, you cannot do it. You do have kind of disability where you do have some activities which you're not going to be able to do. Now, let's talk about how important those activities are. Are those importance very essential in your life, or someone else can help you doing it? So I think that's would take me to this tolerance. I mean, I will agree that some people would have less tolerance for pain, and I will agree that some people would need more opioids to take care of their pain, and I will escalate it to be able to take care of their pain according to their need, but also keep in my mind what activity they're doing, one, and then the other thing is, are they being realistic with their expectations? So the last question is, who should we refer? I think less and less referrals needed. I think pain clinic, they actually are shying away from opioid prescribing most of the time. I mean, I can tell you about Kalamazoo, because that's where I came from. Most pain clinic right now are shying away from pain medication or opioid prescribing, and they will do more invasive procedure more than opioid prescribing, unless those are their patients. So in the old days, whenever you had patients on opioid which you're not comfortable with, you could just have referred him to a pain clinic, and the natural course of that usually, that they will come back to you with more opioid. But right now, you don't see that anymore because they would not take over the opioid prescribing. I think primary care getting hit so bad right now with so many patients. Sometimes they did not even start them on opioid, but they're coming to their door on a very high dosage of opioid and benzos, and they don't know what to do with them. And I hear this over and over and over. I'm not comfortable prescribing that. That's just something out of my comfort zone. I think what we need to do is have less referral. I think we need to reassure our primary care that what you're doing is very good. What you're doing is great. You just need to keep doing it, but you need to be slower. I think one of the problem is, as a health system, I mean, we all been to a primary care. We know our appointment is 15 to 20 minutes. And working in a primary care field, I know that I would get patients who would have 5 different problems. I have to take care of their diabetes and high blood pressure, and then on the list refill of my pain medication. I think pain, chronic pain visits should be a separate visit. Nothing else should be addressed with chronic pain because it takes a long time to be addressed. It takes a long time to be able to relate to your patient and understand him and have a conversation. It's not something which can be done in 2, 3, 4 minutes. It's just not realistic to expect that. I think any person who are on opioid and there's a plan to taper them down, they need to have a psychotherapy support. They have to learn ways to cope with their chronic pain because it's very difficult to cope with chronic pain. I think they have to have Narcan available for them, not just for them, but also for another family member if they were able to get hold of their medication. Anyone has any questions for me about opioids in general? Okay. I think I'm good.